Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time, but please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, Oxytocin and Hypopituitarism, a missing, forgotten hormone, is being presented by Dr. Yuval Eisenberg. Dr. Eisenberg is an endocrinologist at the University of Illinois at Chicago. Dr. Eisenberg studied medicine at Rush Medical College in Chicago and then did his internship, residency, and fellowship at the University of Illinois at Chicago. He is certified in internal medicine and endocrinology. Dr. Eisenberg strives to connect with his patients and provide top-quality medical care. He believes strongly that a good patient-doctor relationship is the backbone for successful medical practice. His goal with each visit is to listen, inquire, and educate, and to assist you with making important medical decisions. Although his main focus is general endocrinology, Dr. Eisenberg has a specialized interest in pituitary and adrenal disorders. Dr. Eisenberg's research interest in the hormone oxytocin and how it might affect patients with pituitary hormone deficiencies or hypopituitarism. Dr. Eisenberg, thank you so much for your involvement with PNA's webinar program. There is going to be a brief delay as we change presenters. Okay, you should see on your end to accept.
How's it looking so far? Are we able to hear?
Looks good. Yeah, I can hear you just fine, and I see your screen.
All right. Well, thank you so much, Tammy, and thank you to the PNA for allowing me to talk about an area of pituitary disease that I find particularly interesting, an area I think that we are lacking in our information, and a place that I'm trying to hopefully shine a little bit more light on as well. The topic, as you mentioned, is for oxytocin, specifically in patients with hypopituitarism. But in order to get there, we're talking a bit more about oxytocin itself and sort of whether or not this is a hormone that we are missing out as endocrinologists that care for patients with pituitary deficiencies. The main objectives then are to spend time going through a bit about what I find is a fascinating area of research, which is oxytocin in humans in a variety of different realms, with a focus on what's been going on of late. So there's a lot that we know about from before, but there's plenty of active research going on about oxytocin effects. The other is then to spend a bulk of the time talking about relevant literature that is out there in patients who have hypopituitarism, and potential derangements in oxytocin. And so it's sort of sad that I'm able in this short time to get through basically the majority of the papers that have been written, but I think it's important to kind of know what's out there for clinical providers as far as in the literature about oxytocin and hypopit. Throughout the talk, I use different abbreviations. I put the most important ones here initially, but just if I mention CDI, I'm talking about central diabetes insipidus, HP for hypopituitarism, and either OT or OXT for oxytocin itself. So it turns out Dr. Henry Dale, was the first to really describe this peptide, this hormone, as having some connection to uterine contraction. The name oxytocin comes from a Greek term oxytocic, which means swift birth, and he was able to extract this hormone from the posterior pituitary of human beings and utilize that for the scientific study of cats, and was able to describe uterine contraction related to these extracts, which is an interesting study, but nonetheless was an important part of the discovery of this hormone. And it wasn't until nearly 40 years later that the hormone itself was the first polypeptide that was sequenced and synthesized by Dr. Duvenaud, I think I'm pronouncing correctly, who ended up getting the Nobel Prize for his work on this peptide. And it turns out in research actually worked much of his career at the University of Illinois, which I was fond to hear. So oxytocin itself is a neuropeptide. It is a 9-amino acid non-peptide, and it is synthesized within the hypothalamus. And much like the more commonly known hormone ADH or vasopressin, the hormone itself is made within the hypothalamus, primarily within the paraventricular and the supraoptic nuclei. And but it is stored within vesicles that are in the posterior pituitary. So created within these nuclei, but stored primarily within the secretory vesicles and the posterior pituitary. It turns out that some of the neurons responsible for oxytocin secretion and production also project to other parts of the brain beyond just the posterior pituitary where it's stored, but there are projections in the figure here describing other areas, including the anterior cingulate cortex and the amygdala, a number of different brain areas which might be important for some of the things we know about how oxytocin functions, but it's beyond just what's made and stored in the posterior pituitary and secreted into the circulation. Beyond the hypothalamus and in the pituitary where it's stored, there are other sources of oxytocin production in the body that include the gonads, the ovary, and the testis, as well as the adrenal gland itself, but the primary source is within the hypothalamus and posterior pituitary. Once it's released into circulation, though, from this location, we do find that oxytocin can be measured in a variety of different body fluids, including serum and saliva, as well as within urine. As far as oxytocin compared to its sister hormone vasopressin, which is also stored within the posterior pituitary, we see that it is very similar in structure, but very different as far as function. When it comes to vasopressin, we're primarily concerned about water balance, and that patients with deficiencies of vasopressin have diabetes insipidus. That oxytocin, though, there might be some cross-reactivity with the effect that similar to vasopressin at the level of the kidney, and there are some concerns when we talk about its use about binding to the vasopressin receptor within the kidney. So these two functions that are listed here on the left side are primarily what was thought to be the function of oxytocin for decades. And we do know that it is very important for uterine contraction and for the letdown of milk, not really the production of breast milk, which is mediated mostly by prolactin, but for milk letdown. And so the majority of knowledge about this, the majority of what you'd read within the endocrine literature even till today is primarily focused on the peripartum period. What's interesting, though, is that there's a lot that has been discovered and is being actively investigated in a number of different areas. And the largest area of active research on oxytocin's function is within the realm of neuropsychiatry. And it turns out that oxytocin, it probably plays a role in a variety of different normal behaviors, and some of which in the lay literature has been described as sort of the hormone of love, the hormone of trust. It certainly seems that it plays a critical role in those aspects of interpersonal relationships. And also, though, in terms of social cognition and attachment behavior between pair bonds, as well as there's some potential effect on memory. So it functions as a hormone from the normal social health, but it also probably has some impact in patients who have a variety of different psychiatric disorders. And what's listed here is not a comprehensive list, but there's a lot of active research going on to see if there are derangements or deficiencies in oxytocin in a number of these different disease states, schizophrenia and depression, in the spectrum of autism disorders, and the potential role for oxytocin as a therapeutic in intervention in a number of these different conditions. As far as endocrinologists are concerned, it turns out there are also a number of other effects of oxytocin that are either being actively studied or some of which we feel are pretty confidently there. As far as metabolism and weight maintenance, as well as feeding behaviors, so satiety, and I'm going to talk a little bit about that in a moment, as well as distribution of fat composition, and bone health in animal models of oxytocin deficiency resulting in osteoporosis that can be improved or resolved by giving back oxytocin. So this hormone exists within a lot of different species, and it turns out there are a number of different things that will stimulate oxytocin release. The biggest of which, as far as the highest levels of oxytocin, are achieved during sex and as a result with orgasm. And in animal models, they use a vaginocervical stimulation to try and induce that. Nipple stimulation, also in a variety of different species, has been shown to release oxytocin. Besides those, it turns out there are a number of drugs that can also induce marked increase in oxytocin, especially MDMA or ecstasy. But then there's a number of sort of normal behaviors that also seem to release and stimulate oxytocin production. So grooming in these monkey species, chimpanzees and tamarins. There's a lot of information about bondedness between a mom and infant and father and infant causing a release in oxytocin. As well as what of a negative behavior, but restraint within rodent models also releases oxytocin. In human studies, the other paradigms that sometimes are used to try and create a rise or release of oxytocin are eating, food paradigms, as well as a variety of different exercise paradigms. As far as oxytocin and neuropsychiatry goes, just briefly to get back to this, what we see here is that there is a lot of active research within the last decade or two going on as it relates to oxytocin and a number of the disease states and normal states that I described from before. This is publications that are not related to pregnancy, because earlier on the numbers may be higher, but that's all often related to peripartum and labor. But this is specifically within the realm really of neuropsychiatry and metabolism. When it comes to the neuropsychiatric behaviors and oxytocin, I think this figure describes some of these other aspects that we know oxytocin probably plays a key role in normal interpersonal relationships. And it again, between pair bonds, between relationships with other people, as well as this as maternal but also paternal behavior, we know that oxytocin is an important regulator of those interactions, as well as, of course, sexual behavior. And it also serves in part to be an anxiolytic hormone. And so there's associations with anxiety and improvement in anxiety, potentially with oxytocin. So positive mood, anxiolysis, and being prosocial is what the primary role appears to be for oxytocin. I'm going to talk a bit about these other aspects of things a little bit later. As far as cognitive function, social cognitive function, some of these are beyond what I have time to talk really about, but social memory and olfactory memory. Someone here was willing enough to tattoo themselves with the molecule oxytocin. Whether that released oxytocin, I'm not certain, but they described the trust. So again, we talk about the oxytocin as it relates to normal and important interpersonal and social behaviors, but within psychopathologies, there's a lot that's going on to try and investigate for deficiencies, derangements in oxytocin in a number of these disorders. So there are trials going on to look at in patients with autism spectrum disorders, whether there's improvement in behavior as it relates to their core disorder with oxytocin treatment. Same thing with schizophrenia. There appears to be differences and derangements, primarily low levels of oxytocin in patients with schizophrenia, socialized anxiety disorder, as well as depressive disorders. in addition to a number of other conditions. Prader-Willi syndrome has a lot of people that are actively researching oxytocin's role in the disease and as a potential therapeutic, as well as in OCD, obsessive compulsive disorder. When it comes to the metabolic effects of oxytocin, there are a number of different organs that appear to be affected by oxytocin production. And here's describing a number of different organs. We're talking about fat tissue, adipose tissue. Oxytocin appears to be a mediator of lipolysis and fatty acid oxidation, as well as being generally promoting a metabolically healthy fat, so smaller adipocytes, less leptin and more adiponectin, in addition to effects that it may have on the liver and muscle to improve sensitivity to insulin, as well as uptake of sugar, of glucose, and potentially effects within the pancreas itself as far as insulin release and whether or not there's some role for oxytocin in beta cell regeneration. Again, areas that we don't know a whole lot about, but they're being actively researched. As it relates to metabolism and body weight and eating behaviors, there are some studies that are out there that describe the effect of oxytocin on some of these situations. And it turns out there have been studies to look at in healthy, normal individuals, food intake after oxytocin administration appears to reduce calorie consumption. Again, this is not a wide breadth of literature, but the publication cited here from Dr. Lawson, who's really an expert in oxytocin from Harvard Medical School, was able to describe oxytocin intranasal administration and in cohort of healthy men reduced about 120, 150 calories with a single spray when given free access to food. There also seems to be some effect on satiety, as well as reduction in reward-driven eating. So not all eating is for the purpose of homeostasis. We go back for the extra cookie or donut because of what's sometimes described as hedonic eating or reward-driven eating. And by looking at fMRI or MRI imaging of the brains of people given oxytocin, you can see that there are reductions in this reward-driven eating when it's being given. The other area that's being researched, and again, Dr. Lawson is one of the pioneers in this area, is in eating disorders, specifically anorexic patients who have restrictive eating habits, and when their disease is not being adequately treated, have low weight. There's evidence that there's lower levels of oxytocin, especially within the CSF, and that they may have a blunted or reduced oxytocin response, but there's a lot that's being investigated in that realm. As a method of weight reduction, and being, again, positive from the perspective of healthy metabolic fat, it's interesting to note that there have been some studies looking at oxytocin as a potential therapeutic agent. And the largest of which, or the most impressive of which, was a study done by a Chinese group who gave oxytocin 24 international units intranasally 4 times a day to a population of men and women over an 8-week period of time, and were able to demonstrate a really tremendous weight reduction. So these were normal individuals. Within a 4-week period of time, they had nearly 5 kilograms of weight loss. And within the 2 months that they were on therapy, at the end of that, on average, had 9 kilograms. This was a very small study. It needs to be repeated. It is actually, there are a number of studies going on to try and replicate some of this, but if it were to be repeated, this would be tremendously, a tremendous improvement on some of the agents that we do use actually for obesity management and weight loss. So there's a lot of potential for oxytocin on that front. And again, as far as fat goes, the studies that have been done seem to promote lipolysis and a metabolically healthy lipid profile that would be favorable from an atherogenic perspective. As far as glucose homeostasis, another area where we're trying to learn more about, but oxytocin levels in diabetic patients also appear to be lower than those that are non-diabetic. There's a bit of a difference depending on whether the patients are obese or not, but in general, it's thought that they're lower in patients with diabetes. And in some, again, small studies, there's a suggestion that intranasal oxytocin might improve insulin sensitivity as it relates to both the fasting state and a postprandial state, and responsivity of the beta cell to a glucose load. Again, small studies, but there's some evidence out there that it might be favorable from that perspective. So the next small section is about oxytocin and how it is administered and delivered. You know that this sounds fairly promising, and there are a number of different ways that it can be given, but I wanted to go through some of what is out there, what's available. As far as the majority of the use of oxytocin is as Pitocin, the trade name, but used for the purpose of the peripartum period. There have been standardized metrics for what a single milligram of oxytocin is supposed to have, which is about 600 international units. When you compare that to what the normal posterior pituitary should have, we're talking about roughly 14 IUs for the normal stored posterior pituitary. When given for promotion or advancement of labor, there is a variety of protocols that different hospitals will use. Generally, this is being done is an intravenous solution that's administered continuously, and so the rate of infusion is somewhere on the order of 1 to 30 million international units per minute as an infusion. Although there are a lot of places, there are a number of hospitals that use oxytocin or Pitocin as a postpartum prevention of hemorrhage. And in this case, it's being given on a dose typically of about 10 international units, either as an IV push or as an intramuscular injection. Some hospitals have opt-out policies, and they essentially give it to almost all women. Other places, there's discussions, or it depends on the situation as far as their risk of postpartum bleeding. The other option, though, is as an intranasal spray, and there are a variety of different protocols that are used. I'm going to talk a little bit later about, certainly in the hypopit population, what has been used, but somewhere on the order of a few international units daily or a couple times a day in kids that's been described, versus 12 to 25 units daily or even 4 times a day for adult populations for different metabolic studies. When it's used on a single dose, they typically are using somewhere on the order of 30 to 40 units as a single dose. The history of oxytocin as a spray is actually kind of interesting. It turns out this was created in the mid-50s by a Swiss company as Syntocinon, the spray that you see here on the right, synthetic form of oxytocin, Syntocinon. And it was approved by the FDA in 1960 for use as a lactational aid for postpartum milk ejection, women that were struggling with lactation. Didn't do terribly well, and so in the late 90s, Novartis, who owned the patent, discontinued their manufacturing because of poor sales. And another interesting twist here was that then, not quite so many years back, the company Retrofin licensed the drug from Novartis itself. And Retrofin, which ultimately I think became Turing or Viera within the US, has the dubious problem really of their CEO and founder being Martin Shkreli, who is this guy who was jacking up prices on toxoplasmosis treatment. And so I think that ended up turning the pharma itself in a more focused direction. They had broader potential, but as of now, they don't really mention oxytocin, which they had planned to use for weight and for a variety of different neuropsych disorders. They don't have any active pipeline planned use for the drug. So as far as I mentioned before, there are a number of different protocols that are used for oxytocin as a nasal spray in a variety of different conditions. As far as some of the concerns, though, there really isn't a lot of data, long-term data, on the use of the drug. There are some potential side effects, and in practice, there are some people that suggest there may be some development of tolerance over time that would lead to a need to either withdraw therapy or reduce therapy in order to make things remain effective. Long-term data in animal models, we're talking on the order of 8 weeks. The longest I think I have seen for human studies, again, most of them end up being very small populations, or in individual case reports, we're talking on the order of a year or 2 at most. As far as listed side effects for the drug, there are concerns about adverse effects in the peripartum as it relates to anaphylaxis potential, which is very rare, but bradycardia, blood pressure changes, in addition to some nausea and vomiting, which can occur. The other concern, as I mentioned before, about the cross-reactivity between oxytocin and vasopressin is that it could, in theory, result in increased fluid retention, as well as a possibility of causing hyponatremia if it were particularly effective at the level of the kidney. As far as where the drug can be gotten and what is considered appropriate monitoring, there really is not a lot of guidance in this area. And as far as the use of oxytocin for autism spectrum disorder, or for obesity management, or even for patients with hypopituitarism, there is no FDA-approved indication for this purpose. And as of now, the only way that they can get the drug is not really through an FDA-approved production process. But there are a number of compounding pharmacies that do provide the drug for patients, either as nasal sprays or as tablets, with a prescription from a provider. The only other way that people end up getting exposed or have chance to use oxytocin are in clinical trials, when investigators can initiate an investigational new drug license, and so it's the other place that people end up using it. As far as what's monitored, typically patients describe their providers measuring serum sodiums to make sure hyponatremia isn't developing, and monitoring medications that they're on. In the case of hypopituitarism, of course, many patients are on a variety of these different hormones. From what I could gather, many patients, or there's some suggestion that patients may need to adjust their cortisol intake, the dose of hydrocortisone they're on. Some may find that they need different doses of desmopressin, although that's not super clear. And then, of course, monitoring for any other adverse effects. So getting to the next bulk of the talk is really about oxytocin and hypopituitarism. And I think there are a number of logical questions that I think the attendees here, I think some of which, or many of which might be patients, are logical questions that I have, that I think that a lot of people also have, that we unfortunately don't have great answers for. One is whether oxytocin deficiency as an entity really does clearly exist. Specifically in patients with hypopituitarism, those who may have posterior involvement and hypothalamic involvement, the thought would be that they are the most logical population to study to find deficiencies or derangements in oxytocin. And whether or not they have low levels of oxytocin, I'll talk about at least what's out there in the literature. The other then next step would be to say, do we know if there is impact of oxytocin derangement on a number of things that seem to be important for its role in normal human metabolism, in psychosocial health, as well as in quality of life for patients with hypopit. And then naturally, one would want to know if there is deficiency or derangement, is whether some of the therapies that are available or could be developed, would there be a role for replacing oxytocin in order to improve some of these measures. So I thought I'd spend just a few minutes talking about why I think we don't really know a whole lot about this area, about oxytocin and hypopit, and some of it is based on a variety of these different issues that we run into. And one is, where is the appropriate place to measure oxytocin? And there is a lot of disagreement and a lot of debate, and there is certainly no standardized way of describing a derangement in oxytocin. And so studies have been done in all of these different body fluids, including the CSF, in trying to look at differences in saliva, or as a non-invasive measure, as well as urine, or within serum or plasma. The other is how it's measured is also incredibly important, is being able to say that there are differences between a population. You want to make sure that you're measuring what you're interested in. And there is also not a standardized method for this being done. And so there are a number of different assays that are used in research, including radioimmunoassays or enzyme-linked immunoassays, ELISAs or EIAs, for the purpose of trying to establish what a normal oxytocin might be. And the other is that the processing of the sample that you get is also variable. So there's a method of trying to remove some different interfering substances that uses a solid phase extraction. And in this figure, what they're describing is you're adding sample that you're able to remove out some of these interfering substances and be able to accurately measure oxytocin at the end. And what you see is that there are a lot of different studies have been done to try and document in a whole host of different body fluids, both either in a controlled normal setting or a baseline in a stimulated setting in men and women, with an ELISA or EIA versus radioimmunoassay, as listed here, whether there's an extraction step or not, there isn't any extraction, and you see a tremendous variation in different body fluids of what normal oxytocin levels might be. So these are presumed control subjects, ranging anywhere from 4 or 5 picograms per ml in an extracted EIA compared to several hundred in one that wasn't extracted, to 200, 400, 500. So there's a lot of variability, and we don't really know what the normal values should be. The other is whether when we're measuring oxytocin, are we really gathering what is an accurate representation of how much is really present, is another issue that we struggle with, in that oxytocin does appear to have pulsatility. I think this is a study that Dr. Lawson completed that looked for frequently sampled blood measures of oxytocin in a group of men that were monitored for 6 or 8 hours period of time, and you see a lot of variability in pulsatility over this duration of time. And so some studies aim to do that with to sort of combine these and figure out what the mean might be. But you imagine if you measure here, you have one value, and you wait 2 minutes later, you may have quite a markedly different value. So the pulsatility is another problem. The other is recruiting patients is always difficult in a disease that as rare as hypopituitarism. And the estimated prevalence and incidence listed here are, it's not entirely clear that that applies across different countries. I believe these numbers come from a Spain cohort, but 4 or 5 cases every 100,000 every year, or 45 cases per 100,000 in the whole population are very rare. Just as an example, diseases that also are still relatively rare and studied more often, sort of hard to compete when there aren't that many patients with the condition. So the next section is really an aim to describe what's been studied thus far. And it turns out these publications have all come out really within the last several years to look at patients specifically with hypopituitarism. I'll spend some time in the beginning talking about the research studies that were done, mention also a couple of very interesting case reports, one of which is very recently published, and then talk a bit about sort of what I gathered in preparing for this talk from reviewing kind of lay literature and patient experiences on the web. So the first study that I'm going to talk about is in patients who are survivors of craniopharyngioma, and this was published back in 2016. And these were childhood-onset craniopharyngioma patients in a pretty large cohort that's studied by Dr. Hermann Müller in Germany. And these patients who had been identified early on and have been followed for many years have yearly investigation or yearly meetings, support meetings. And at one of the meetings, I believe they decided that they would pursue investigating oxytocin as it related to their care. And so they had, all these patients were patients with craniopharyngioma. As far as the questions that they were attempting to answer, they looked to see whether patients with craniopharyngioma, many of which are really, the majority of which had anterior hypopituitarism as well, whether they had lower levels of oxytocin or different oxytocin levels compared to controls. They also then gave them breakfast and took that opportunity to try and use a standardized meal as a measure of change in oxytocin. compared to controls. And then they also wanted to see whether or not in their population that they had well documented information about which pituitary axes were affected, where in the brain was affected, whether that made any difference as far as oxytocin derangements or oxytocin differences. So some of the measures that they end up utilizing were they had information about patients, at what age they were at the time that they had their surgery, age at which they were being evaluated with these oxytocin metrics, and they also had information about their MRIs, so they were able to grade out what hypothalamic injury there might be involved. So the craniopharyngioma is a tumor that's suprasellar in origin from Rathke's pouch, and typically does affect the hypothalamus and has issues with vision impairment often. But they can grade either with no hypothalamic involvement, anterior or anterior and posterior involvement. They had information about radiation exposure, radiation treatment, and whether or not they had posterior involvement as evidenced by diabetes insipidus, as well as whether there were differences in gender. Their particular measurement, as we said, is very important. So they looked at saliva and collected saliva for these patients both before and after a standardized meal. They chose to use an extraction step in their process, and the lab-specific method that they used was an EIA. I think one of their collaborators had developed rather than any of the commercial products. So what did they find? They were able to recruit a total of 30 patients with craniopharyngioma and a relatively even split between men and women. And then they were able to match nearly 70 patients, or subjects really, that were used as controls. You see that there was some difference, although I don't think it reached statistical significance, of the craniopharyngioma patients generally being younger than the controls that they recruited. But unfortunately, what they didn't really see a huge difference with were the measured oxytocin values. And so they had measured oxytocin both before meal consumption and post-meal consumption. And at least initially, the baseline values of oxytocin compared to controls were not different. If anything, the actual mean was higher, but didn't reach statistical difference. There might have been some suggestion also that there were sex differences. Again, not that met statistical difference, but it was surprising somewhat to not see tremendous difference between patients with craniopharyngioma compared to controls. So as described here, there really was no difference in patients compared to controls. And they even looked within the subpopulation of patients with hypopit, those that had evidence of posterior involvement with CDI didn't make a difference as far as their measured oxytocin value. When you compared men to women, again, didn't reach statistical significance. Whether or not they had radiation exposure didn't reach statistical significance. What they did find, as far as those with the lowest measured values of oxytocin, it turned out, interestingly, were those with grade 1 hypothalamic lesions. And these were people then again with just anterior involvement, and they ended up having lower values than both zero grade or no affected hypothalamic lesion, but even lower than those that had both anterior and posterior pituitary. It's not a great understanding about why that may be, but nonetheless, they were able to show that these were the lowest level of oxytocin was in that cohort. As far as the next step that they took was to see whether there were any neuropsychiatric benefits or differences with the same population by administering oxytocin intranasally. So again, childhood-onset craniopharyngioma patients, Dr. Mueller's cohort from Germany, and what they looked at then in this case with research questions they were trying to answer were whether giving oxytocin intranasally, whether they would be able to document change both in saliva and urine as it relates to oxytocin, given intranasally. The other was then whether there were any changes in social cognition in these craniopharyngioma patients when given oxytocin intranasally. So in this case, what they chose to measure were a couple of questionnaires that included things like assessment of mood, assessment of functional capacity in these patients, and the other was to see if they had any differences in emotion recognition, which as I mentioned before, is one of the things that was thought oxytocin plays an important role in. In this case, they chose a paradigm that involved voice and not vision, partly because many of their patients did have visual impairment but were able to recognize voice. So they used an actor who was describing, who used a sort of pseudo language to express a number of different emotions and tried to have patients and controls identify the appropriate emotion. As far as measurements of oxytocin, they used both saliva and urine. Again, they used an extraction method. At this time, they were using a commercially available radioimmunoassay through Diagnosis, so a German company, and they measured both before and then after oxytocin administration, 45 and 90 minutes after. And the results, in this case, they had a very small cohort of patients that they were able to administer and check for. So 10 patients total, 5 women and 5 men. And what the figure describes here is that they were able to show that the administration of the intranasal oxytocin did result in measurable changes, both in the saliva of the patients and in urine of the patients. So it seemed to suggest that the oxytocin was being absorbed. What they did not see, though, was a tremendous difference with the oxytocin administration in these measures of emotion recognition. What they found only improvements within those that had grade 1 lesions. Interestingly, again, that's the population from before that had the lowest levels. And the most improvement that they found were in negative emotions, anger and fear. Being able to assign the correct emotion was helped, at least in that population, by oxytocin. And again, very small numbers, but you can see that both pre and post administration, this black line is for those with grade 1 lesions, I believe, and the dash lines are in those with grade 2 lesions, that there were improvements in their correct responsiveness once they were given oxytocin, again, a single spray. Hypopit again, it's a very similar sort of study in oxytocin concentrations with in patients with reduced, trying to assess for reduced empathic ability. Was another study done last summer, published last summer, by Dr. Daughters, Dr. Rees, and Dr. Manstad in Cardiff University in the UK. And their research questions were somewhat similar, but looking to see if hypopit patients had deficiencies in oxytocin, and whether those with diabetes insipidus, which they presumed would have the lowest levels, whether they would perform worse than others on empathy-related tasks compared to controls. So what they attempted to measure were, again, a number of different questionnaires related to interpersonal relationships, a measure of, again, sociality is related to autism quotient, and then relationship structures. And they measured saliva as well, with the extraction step included. And they used what's probably the most commonly used ELISA at this point in research study, which is this Enzo Life Sciences product. They chose to use slightly different tasks for emotion recognition. And in this case, they used reading the mind and the eyes, as well as the facial emotion recognition task. I think on the next figure, I have an example of what it was they looked at. And it turns out they also, this is a validated study test for emotion recognition by interpreting the eyes of a subject. So again, these are actors that portray a given emotion. The subjects are given only exposure to what the eyes of that actor is, and they're able to sort of describe what emotion they think that the actor's representing. In a similar way, there's a facial emotion recognition task, this FER, that has different intensity of a variety of emotions, anger, sadness, fear, happiness, and they're also able or asked to describe or click on what they think is the proper emotion at different intensities, less intense and more intense, all the way upwards of 100. So the results of this study was the population they recruited was roughly 45 patients. In this case, they did have slightly more females than males. And they found that in general, the population had higher BMIs than those with hypopituitarism compared to healthy controls. In the figure that they have in their paper, they describe actually hypopit is this entire group, these 35 patients. compared to healthy controls. They use both patients with posterior involvement, they label as CDI, compared with those as a clinical control. So these are hypopit patients, anterior hypopit without posterior involvement, and then again compared to healthy controls. So it's a little bit confusing, but they end up combining this cohort because what you see is that though that population of hypopit appeared to have lower levels of oxytocin when compared to controls. They also appeared to do worse than healthy controls as it related to these different tasks, so worse on the reading of the mind in the eyes, as well as the facial emotion recognition task, and that when they looked at oxytocin levels, it seemed as though they reasonably predicted, at least for the easy measures of reading a mind's eye, for those with central diabetes insipidus. The most recent publication came out just earlier this year. Again, a German group, I don't believe directly involved with Dr. Mueller's cohort, but in this particular population, they were attempting to answer a number of somewhat similar questions, trying to see, again, specifically craniopharyngioma patients and whether or not they had lower levels of oxytocin compared to healthy controls. They put these patients through an exercise paradigm and tried to see whether there were differences related to exercise, as well as looking at oxytocin as a predictor of neuropsychiatric issues, and then whether or not any other factors influence the measured levels of oxytocin. They did a number of questionnaires, similarly looking at things that we think are related to oxytocin, like depression, anxiety, and empathy as an empathy quotient. In this case, they measured oxytocin in saliva, underwent the extraction step, and then utilized an RIA for their method of measure. And what they saw, again, what the results consisted of was both a baseline level of oxytocin for craniopharyngioma compared to healthy controls, a stimulated value that was created by putting them through an exercise paradigm on a bicycle. What they show here are the values of oxytocin and a number of other metrics for craniopharyngioma compared to healthy controls. Again here, unfortunately, at baseline, they did not really see a difference compared to healthy controls. If anything, they saw a mean of higher levels of oxytocin at baseline compared to healthy controls. The stimulated values were also not different statistically with CP patients compared to healthy controls. They did find more depression and anxiety, trait anxiety in that particular population. And so again, baseline values of oxytocin were not different, craniopharyngioma compared to healthy controls, and there were no differences when they looked at those patients with diabetes insipidus and those that didn't have it. The only thing they were able to show were stimulated values of oxytocin were rose less than in healthy controls, so they had a blunted response, and that depending on the grade of injury, there appeared to be some differences in oxytocin. But again, no differences in the baseline values as far as metrics compared to healthy controls. So I think I'm going to move on here to the two very interesting case reports that are out there in the literature about the use of oxytocin for patients with hypopituitarism. The first one came out in 2016, and this was parent observed improvements related to oxytocin in a child with craniopharyngioma. So this was a 6-year-old, it was a child who had resection of craniopharyngioma at age 6, who developed postoperatively, not unexpectedly, panhypopituitarism, including posterior involvement with diabetes insipidus, and also suffered with hyperphagia, with hypothalamic obesity. The other aspect here, though, was that this child had a number of issues related to sociality and interpersonal relationships. And so what was described were that this child was socially isolated, that even within his own family, I believe, he had lost interest in contact with other members, including the sibling, and that he had a variety of obsessive and compulsive behaviors that were frustrating to the patient and frustrating to the family. And so they opted to consider and try and use oxytocin for therapy. The child was given intranasal oxytocin twice a day. And for the initial period of time that it was used, it was described in the case report as a tremendous change as far as behavior. So within a very short period of time, the family had observed a desire to socialize for the child, as well as interactive and quiet play with his sibling. And there was some change, though, that was described as far as the child's reported thirst. And so after a period of time, about a week of therapy, there was a cessation with concerns initially about hyponatremia. I don't believe that actually was documented, but there were some concerns. And after cessation, the behaviors that were bothersome returned pretty quickly. They went on to describe that they switched or reduced dosing to 1 to 2 units twice daily, and the positive social interactions returned and were improved. And I believe the child was treated for a total of about 14 months. What they didn't see any improvement was metabolic status. And so the hypothalamic obesity remained. There was no significant metabolic benefit, and the obsessive and compulsive behaviors didn't change. The other case report that came out very recently in the JCNM was another study of a single report of a child or a young adult with hypothalamic obesity who was also post-craniopharyngioma resection, who was treated with a combination of therapies, initially just oxytocin and then naltrexone. And this is being guided by a very thoughtful and invested mom who wanted to provide therapy for her son. The child had resection at age 8, and again, like the other, had not surprisingly post-op hypopituitarism, including a thirst disorder with diabetes insipidus. And in this case, had issues also with hypothalamic obesity and complaints of hunger that were pretty severe, as well as eloping in the middle of the night for food, to the point that family couldn't really take him to grocery stores, had to really monitor what he was taking in, what he had access to, because he would steal and stash. And what they showed was that post-surgery, he had significant weight gain. It seems as though to start off with, he was probably at the higher end of the weight spectrum, but after surgery had a significant rise in weight that was very difficult to control. And I think all of these years were struggles with a variety of different diets to try and improve his weight status. But it wasn't until they added oxytocin that they saw a significant improvement. And in this case, 6 units were given on a daily basis, and within a 10-week period of time, he had lost nearly 5 kilograms. I think it was 4.5 kilograms. There was also qualitative improvements in satiety and in his preoccupation with food. They described that he still had highly palatable food desires, like we all do for cookies and such, but that there was overall improvement in his weight and his behavior. Along the way, there was a hope that maybe naltrexone would also curb some of this appetite issue, and so that was added, and there was some titration in the oxytocin. It turned out 9 units resulted in worsening of some of the food behaviors, but overall, over the years period of time of being on therapy, there were improvements to the point where he could have partial and then sort of full food access without concerns about additional weight gain. There are a lot of confounders. Of course, this is a single patient. Their child was going through puberty at some point, so here had to have induction of puberty with testosterone therapy, but nonetheless, significant changes for this particular child when given oxytocin intranasally. So there's not a whole lot here left to talk about, but what I found in looking through a variety of different sources to try and get a sense of patient experience with therapy is that there probably are a lot of patients that do utilize oxytocin in the setting of hypopituitarism. And what I ran across in looking on different Facebook groups for experiences with oxytocin was this letter, which if you have a time to read at some point you can, but really expresses the frustration that I think patients have with not being able to get something that they think may have some potential benefit for them. I think the struggle from providers are that we don't have strong evidence, as I've shown you, for what it is that we are really replacing, and being able to define the deficiency in a way that we would be able to match more closely with other hormones that we replace. But nonetheless, patients with their experiences, are frustrated that they can't find providers who are willing to consider therapy. And I think providers are also equally frustrated, or should be frustrated, with the dearth of data that we have, and wanting to really advocate for improving patient care by improving what we know from a research perspective. As far as what's on the horizon, when you type in oxytocin in clinicaltrials.gov, it turns out there are a lot of investigators that are looking at oxytocin in clinical study. And in this case, it pulled out, when I searched, there were 151 studies being actively done, recruiting or enrolling by invitation. Some of these are totally irrelevant to what we're talking about today, but certainly it's an area that's being actively investigated. As far as those that are specifically related to metabolism or to hypothalamic obesity, probably the most relevant study going on is by Dr. McCormick through the CHOP Hospital, Children's Hospital in Philadelphia, looking at oxytocin therapy on an 8-week duration, placebo-controlled, randomized crossover study, the way things really should be done, with intranasal oxytocin for mostly children or childhood survivors with hypothalamic obesity. The other is Dr. Lawson does have a study looking at oxytocin in obese adults, not with hypopituitarism, but those with both men and women that are obese, to see whether or not therapy for 8 weeks duration could cause weight loss. So in summary, I think we have pretty good evidence it's not just for uterine contraction and lactation anymore. There's a lot of different areas oxytocin has potential function, that there are challenges in measuring oxytocin and issues with lack of standardization of that process, and then that we have limited or minimal data in the population that I think we should know more about. And those with hypopituitarism, we struggle to know what deficiencies or derangements they have in oxytocin, and that patient experiences, which we know seem to be favorable, probably really need to be translated into clinical study, where I think unfortunately we're not quite there yet, but hopefully that's where things will go. I think that's the end of my talk.
Excellent. Thank you so much. We do have questions. First question, can there be studies where oxytocin is started at a very low dose, maybe 6 IU once a week, and titrate and have patients' family note changes? Same could be done with placebo.
So I think that's an excellent question, excellent thought. And I think Dr. McCormick is doing the closest thing to that. As far as there are interventional trials in, again, autism spectrum, which does rely on parental involvement and titration according to symptom change. I think it's a great thought. It's something that hasn't caught on quite as well as it probably should.
Okay, thank you. Any link between oxytocin and initiating sexual intent, specifically initiating?
So I guess the question is about, because I'm a little confused about the question, is oxytocin, whether or not it results in sex seeking behaviors, and that I hadn't seen any specific studies on. So meaning give oxytocin and see whether that produced a difference in sex seeking behavior. We certainly know that in the act of sex that oxytocin rises, but whether or not prior to that there are differences, I don't think we know terribly well.
Okay. Any ideas around making a combination DD-AVP/oxytocin spray test?
Spray test? Is that right?
Yes.
Okay. Well, so I mean, we primarily use of oxytocin or of DD-AVP as a nasal spray is for treatment for diabetes insipidus. We certainly use DD-AVP in water deprivation testing for documentation of DI. I think the concerns in part are the formulations of oxytocin that could be created may have a potential to bind at the level of the kidney, and in fact, you'd rather have the effects be oxytocinergic rather than being vasopressinergic, meaning if the oxytocin and vasopressin are combined and they both work similarly, you'd end up with more hyponatremia and edema. And so in the future, that sounds great to be able to give both in one single spray. I'm not aware of anyone working actively on that.
Okay. How do we know if we are anterior hypo? My tumor was removed via craniotomy when I was 4 months pregnant in 1986, then radiation 5 months later. My tumor was on the pituitary stalk at the optic chiasm. And then a follow-up to that is just diagnosed with diabetes insipidus in 2015.
So there's a little bit, it's a little bit confusing, and when you see patients, what they've been told and how it's written is sometimes a bit different. But what typically, pan-hypopituitarism really should involve both the anterior and posterior pituitary. When we talk about anterior alone, the implication is that someone does not have diabetes insipidus. So we certainly have lots of patients who had surgery or have tumors that have central adrenal insufficiency, thyroid disease related to pituitary dysfunction, hypogonadism related to it, but they don't have posterior involvement from diabetes insipidus. What we really still don't know is, even those that have CDI or diabetes insipidus, that's related to the posterior pituitary, what does that look like as far as the oxytocin? So we really don't know.
Okay. You have touched on many personal battles I've had over the last 30 years. I'm happy to offer myself up as a hypopit patient for clinical trials. We lack many hormones, aminos, etc. that normal people have, but for some reason doctors do not replace these hormones post-op. Seems after my pituitary surgery, nothing interested me and it was difficult to engage, especially while raising children. It was a real effort to feel one way or another about anything, and after 3 decades I still feel that way. It increases tenfold when I'm tired. Does lack of oxytocin have anything to do with the constant battle with apathy?
Boy, that's you just sort of nutshelled the patient experience with this potential issue, and I think that the answer is we don't know, and the answer is it certainly needs to be investigated further. And you would be a perfect example of someone who we would hope, if we could define that there was some derangement or deficiency that we could replace adequately, that we would hope there would be improvements in some of that experience. I think that's my hope, is that that's where things go. I don't know that we have great answer at the present moment that giving you therapy in the fashion that we have access to is the right answer.
Okay, I'm wondering if there are any reliable labs that test oxytocin levels in the human body. Do these labs test both serum and urine levels? I know that Meridian Labs in Washington State does a 24-hour urine test, but I question if the results are reliable. Would a 24-hour urine oxytocin lab level be stable and reliable? Many compounding pharmacies are selling oxytocin in a variety of delivery systems. Do you think the sublingual tablets are as effective with absorption of oxytocin as the nasal spray? Since the nasal spray is not sterile, I'm concerned about infection. I got pneumonia after starting the nasal spray, and I question if it was the oxytocin nasal spray that caused the infection. I am pan-hypopituitary and replace most hormones, including oxytocin.
So that's a lot to unpack there. As far as the last aspect of things, as far the compounding pharmacy tablet versus nasal spray, again, something that we just do not have data to support that one is superior over the other. Certainly a tablet that you would swallow, the thoughts are that it would be broken down pardon me, in the gut, and so sublingually it would still be exposed to mucous membrane and potentially be absorbed. There were concerns about a compounding pharmacy use of, now I'm blanking on exactly what the disease state was, but I believe it was a steroid that ended up being infected with some fungus that resulted in meningitis. And so I certainly understand some concerns about that, and that's the unfortunate aspect here, is that we don't really have an FDA-approved indication that's being monitored as far as drug production and then delivery. What was the first aspect again, Tammy? Was
reliable labs.
Reliable labs, very good question. Yeah, excellent question. So what I would say is, I don't think that they can be, that they are terribly reliable. They have their own set of what they describe as being a normalized value, but that isn't supported in the population that we'd be interested in, again, with hypopituitarism, being able to just sort of define a deficiency and then replace. And so they will have a normal reference range, but that's not super clear that that is a safe thing to reliably use. I know there are some providers that do use that. When it comes to the investigators, the struggle is with the methodology, as I've described in the different studies. And ELISA is the best that's available, but even that, there's questions about what we're actually measuring. Are we measuring true oxytocin? Are we measuring some cross-reactivity with vasopressin? Is there some breakdown products? And there are a number of investigators that are looking toward LCMS, or liquid chromatography mass spectrometry, in order to be more clear that we are measuring what really there is. And so that should be on the horizon within the next few years, a reliable method. And it doesn't take long, I think, after that we can really know in this population what's low and how do we replace potentially with sprays or tablets or whatever can be formulated.
Interesting. Okay, and this is an excellent question, and I have the same question. What's next, and how can we help?
Oh boy, yeah. Well, we need and I need to continue to talk to colleagues who have the experience and the time for research to engage with patients who are struggling with this disorder. And I myself have been trying to recruit patients, or have been recruiting patients, hypopit patients, with a similar method to what I sort of described, to try and document derangements in oxytocin in blood and saliva, and being the openness of this group to be participants in clinical study is what's the best that you can do. And I think my job is, as an endocrinologist who has an interest in this, is to try and find other people with similar interests and other people with a lot more research experience, because most of my day-to-day is patient care. And so, just trying to continue to advocate for an area that we just don't know enough about.
Okay, I want to thank you for covering this topic. I am pan-hypopit, and I have been replacing oxytocin sublingual for 2 years. I feel it makes a difference, and I hope research continues and doctors are more willing to prescribe oxytocin for their patients. Not a question, but good comment.
A nice comment, sure.
Somebody asked how we can share this with our endocrinologist. We're actually recording this webinar, and it will be available on our website at pituitary.org within hopefully the next few hours. Hopefully I can get it edited and posted today, and I will email you when it is available. Next one, my observations of people with hypothalamically involved patients is that they lack social motivation. I'm frustrated that the studies to date do not look at more applied and meaningful repercussions affecting social impairment. What is the best way to influence researchers to study the more meaningful consequences of oxytocin, such as poor socialization and motivation?
So that's I agree with the first aspect of things as well, and that was part of why I decided to try and get partly involved in study, was experience with patients with interpersonal relationships they may have, and even in their interactions just with clinicians, that there appears to be some that are affected by the injury that they've experienced, and whether that's oxytocin related or not, I think is what we're trying to figure out. As far as that being the primary aim, or the area that should be actively investigated, I think what it involves is not only including endocrinologists who are seeing and treating patients for hypopit, but trying to involve psychiatric colleagues who really have the expertise, psychiatry and psychology, who have expertise in being able to assess for deficiencies in sociality and be able to come up with research studies that would really aim to try and document improvement. Obviously, a lot of these patients that people are describing, that they've had a personal experience that it has been beneficial. What we want to be able to do to be able to get people on these drugs is to be able to show in a clinical study that they have sociality improvement. And that would be, we replace everything else for patients with hypopit. In my mind, at some point in the future, I hope this is included in our arsenal. We just don't really have the evidence to support its regular clinical use yet.
Okay, what is your awareness of the effectiveness of oxytocin delivery using sublingual approaches versus sprays?
So I think I touched a bit about on that. Is this that mucous membrane absorption should probably be similar, but I have not seen good pharmacodynamic studies to show one versus the other. Again, when it's a compounded pharmacy and you're using one versus another, there also is differences in the formulation. So one nasal spray is not equivalent to another nasal spray, like it would be if this was something that we could get, that there was approval for from the FDA perspective. So it's hard to say.
Oh, makes sense. Thank you. I hope you get the energy to continue with the studies. I am Pineapple Pitt from craniopharyngioma. Good luck. I look forward to improvements in our overall well-being. Again, thank you for taking this seriously and trying to help. Then another comment, are oxytocin levels a meaningful indicator of a functioning oxytocin? Wait a minute, let me try the generic system if the HPA system is broken. Studies that indicate the existence of oxytocin levels may be meaningful in a person with hypothalamic damage and CDI, correct?
So that is a good point, and that's another arm of the studies that need to be done is deficiency or difference compared to a normal population doesn't necessarily translate exactly into a deficient system. So that we have a lot of redundancies in a lot of endocrine systems, fortunately. And so just hitting the hypothalamus doesn't necessarily mean that you're going to either be able to measure a single value or difference in oxytocin, nor does it mean if the measured value is normal that someone may still have a derangement. So I think that there may be adaptive changes. Let's say you injure the hypothalamus, that other areas of the brain or even peripherally are trying to compensate, and that might impact what it is that you're measuring. So the duration of the area that's involved and the sort of the duration of the injury is probably also an important part of future study that we, again, a lacking component.
Yeah, I noticed some of the studies measured numbers and others measured changes in behavior. So
right,
I
changes
guess
in behavior and changes in value. So not only
right.
is it where it's binding and acting, but if someone who has a problem, maybe they go from a normal number, but they just don't get to where it should be when they're active or they're engaging in sex or they're whatever it might be. Another place that for potential.
Mm-hmm. Well, this has been fascinating. I don't see any more questions. Amazing presentation. Thank you so much for providing this information on a much appreciated subject. Another thank you so much. And for what's next, if there's anything that the PNA can do to help, we're certainly on board. So
wonderful.
if there's anything that we can do to help, let us know, and maybe we can work together and maybe make some progress.
That sounds great.
Another thank you. God bless you all.
All right.
This concludes today's webinar presentation. We appreciate you taking the time to join us. If we did not get a chance to answer your questions, which we did get a chance to answer the ones that I saw, but you can also email us with questions to webinar@pituitary.org. If you missed any part of this or would like to share this with family, friends, or even your doctors, it will be available on our website, pituitary.org, after it's edited. There'll be a brief survey after the webinar. Please fill it out and help us provide you with the information that you need. Thank you again for joining us, and Dr. Eisenberg, thank you so much. Everybody enjoy the rest of your day.
Thanks so much.